Actually, the meeting, I have 4 interesting cases, but if time permits, we can discuss the 4 cases. I mean, what I have planned, 10 minutes for each case and 5 minutes for discussion. So that time we can share our knowledge and other thing. But if more discussion mean, we can keep it as 3 cases. Okay. Thank you, Ganesan sir. Thank you, Dr. Alagamai. Okay, for coming agreed for the panel members. And this one of the case referred from our colleagues to here, tertiary care center. So it's a 52 years old gentleman from Tirupati, and he doesn't have any comorbidity and not alcoholic patient, but he had a history of jaundice for 4 months, treated with all sort of liver supportive medication. That time the gastroenterologist, they evaluated very well the etiology for liver disease, viral serology, metabolic, autoimmune, and as the patient, the jaundice progressively increased, associated with pruritus and pale color stool, and they referred here for the further evaluation and management. Here, low-grade fever on and off for last 3 months. He had a significant weight loss, more than 10 kg. Might be partly due to the poor intake or the most of the time the food restriction because of the jaundice. So the combination, and he had a loss of appetite also was there. As usual, most of the patient will go for some native medications because of the long duration of jaundice. This patient also had a history of some native medication. But no other organs, suppose, doesn't have any respiratory symptoms or renal or abdominal distension or anything except jaundice, and no GE bleed or altered sensorium. He had a pale color stool along with some kind of the oily stool, mostly might be due to the cholestasis. Past history, he had a childhood history of jaundice that was resolved spontaneously, no past history of blood transfusion. This was when we saw in our outpatient, that time the lab report, what they had done a few days ago, that showed there is a total bilirubin 28, direct 25, total protein 7.4, albumin 4, and alkaline phosphatase 278, ALT and AST, more or less near normal, is slightly elevated AST, creatinine normal, INR 1.47. Outside ultrasonogram showed fatty liver. There is no IHBRD. There is no focal lesion, portal vein, all are normal. So he came, so I told him better for admission because already for more than 3-4 months, the cholestatic jaundice, we have to detail evaluate. The 10 patient conscious, oriented, April. Clinically, icteric, no other peripheral signs of chronic liver disease. And all the vital all are normal. Abdomen examination, mild hepatomegaly, that's all. So we did the reason for blood test at the time of admission. So the total bilirubin was 42.8, direct 41.7, albumin 3.7, ALT 31, AST 45, alkaline phosphatase 310, GGT 36, INR 1.47. Otherwise, the basic parameters, the hemoglobin, WBC count, platelet, all were normal, renal function. So he had a cholestasis. So what we thought, okay, already they've been evaluated, but we repeated the test here also because when we did it, almost serology, A to E, all were negative, and autoimmune profile negative. We did a metabolic workup also with quickly, and we all negative. Peripheral smear shows normal, and LDH 215. So as a patient has a history of some native medicine, so we thought, okay, some kind of the jaundice because of the native medicine, it would have been worsened. So we wished to do the liver biopsy And and we thought, okay, we can go ahead. Sometimes what we will do, the patient have chronic cholestasis, we will do TPE, plasma exchange also, just for the symptomatic improvement. So the liver biopsy showed the chronic hepatitis with a mild portal. So that term chronic hepatitis based on the mild portal inflammation, and centrizonal canalicular cholestasis is representing the chronic cholestasis. That's nothing new. And there is no features of fibrosis or cirrhosis, no evidence of granuloma, infectious disorder or malignancy, no evidence of ductopenia, all are normal. So only the chronic cholestasis patients, like a DILI, how it will come, some kind of the inflammation, that's enough. So we subjected him for the therapeutic plasma exchange. We know this sometimes will give the symptomatic improvement. So the first cycle usually we'll do once in a day. Normally our idea was to bring down the jaundice level close to 10. So after that, normally once the liver get regeneration, it will pick up. So we did a 4 cycle. Okay, so that time from 42 total bilirubin, it reduced to 24. So that time only the CT report, official report, we got it. So the CT official report, they mentioned, apart from the routine, the liver architecture, they mentioned there is a peripancreatic region, that portohepatic, there are some nodes. It comes around 3.8 into 3.5 centimeter in size, along with some para-aortic, paracaval, retrocaval, perisplenic lymph nodes. CBD is normal, nothing. It's not, the node is not causing obstruction to the patient. Pancreatic duct, not visually, more or less normal, that's all. Yeah, hepatomegaly. So our radiologist, because whenever you are going to take a CT scan, so nowadays we know the COVID time, even before that also, usually the chest cut, they will take it. And they noticed there was some node in the pretracheal, there is a mediastinal node, that is a peri and paratracheal node. So they mentioned that node also, whatever we have marked here, the plus mark, almost significant node was there. So as the node is significant in the mediastinal, and so they thought, okay, somehow we are missing the tuberculosis or tuberculoma, because sometimes the infiltrative liver disease might be due to the TB. That's why alkaline phosphatase is slightly high, and the cholestasis. So, but already we have done a liver biopsy, no granuloma, only mild inflammation in the portal area. So we thought, okay, we can do the biopsy from that mediastinal node. So, and the endo-ES guided FNA-C was done. So that time the node showed almost 4.8 into 3.7 centimeter at the incisor level, 25 centimeter from incisor level. And we have taken biopsy only from mediastinum, but at the same time we screened the portocaval node and other thing also using end ultrasonography. The biopsy turned to be the Hodgkin's lymphoma from the mediastinum. So because it showed the Reed-Sternberg-like cells with predominant nuclei. If you see, there is arrow mark in the left picture. You can see that is a mononuclear cells, and in the background of the reactive lymphoid cells. There is no granuloma, there is no metastasis or anything. So once it turns to the lymphoma, usually our knowledge in the lymphoma, usually lymphoma can manifest as an infiltrative liver disease. It might be due to the jaundice to the patient, everything might be due to the infiltrative disease. Okay, instead of TB, we initially thought, okay, it comes as a lymphoma. But we once again told to our pathologist, please relook into that, because they only reported mediastinal lymph node as Hodgkin's. Whether it's an infiltrative liver disease due to the lymphoma or not. But he did all the immunohistochemical staining, everything to the liver biopsy also, and he clearly told liver parenchyma appears normal. There is no infiltrative liver disease evidence except the mild the portal inflammation, that's enough, he said. So this is all the immunohistochemical staining for the mediastinal node. So the CD30 strongly positive, and the other markers, because to differentiate the Hodgkin's versus non-Hodgkin's and all the things. So it is confirmed case of Hodgkin's disease, but how to explain the jaundice? Because it doesn't show the inflammatory, and whether it could be due to directly either the history of whatever our earlier diagnosis suspected a DILI, drug-induced liver injury, the things. So we searched the literatures and other. We did the whole body PET scan once the lymphoma comes. If you see here itself, we can see there is in the chest region, the activity, the gamma camera picks up the activity in the lesion. In the abdominal side, we can see there is a paraortic area, that's the things. So chest as well as the abdominal area, the activity of the uptake, the FTG, the uptake. So it shows the confirm. There is a here also. These are the few pictures of the whole body PET scan. Shows everywhere the activity uptake. If you look into that here, the liver doesn't show. There's no much activity uptake also. So this is a whole body PET CT report. There is no metastasis in the bone or any other area. So only the nodes, all the level nodes. So the diagnosis arrived at Hodgkin's lymphoma, unharbored stage 3S with B symptoms. The cause of jaundice, when we search literature, it showed the paraneoplastic syndrome. So we had earlier the same kind of the experience, not with Hodgkin's lymphoma, with the renal cell carcinoma. A patient was referred from CMC Vellore with the renal cell carcinoma with cholestatic jaundice, bilirubin of 50 plus, 55 was there. They said, because they thoroughly evaluated in CMC Vellore, they said patient is not operable for the renal cell carcinoma because of the liver cell failure. Liver cell failure, that time only jaundice. So the patient came. This happened 2 years ago. I think not 2, almost more than 3 years ago, the patient. So that time, we diagnosed that one also. Renal cell carcinoma also will cause a cholestatic jaundice. If you do the biopsy, everything will be normal. By removing the tumor from the site, that is the treatment. The jaundice level gradually disappeared. This is called Stauffer's syndrome. Then we published that one, the Stauffer syndrome in renal cell carcinoma presenting in colon. So the same experience here also we helped with that. Here also the patient's Hodgkin's lymphoma and the paraneoplastic manifestation, there are the hypotheses are there. It will cause severe form of cholestasis. So here this patient, we started the prednisolone as per our medical oncologist advice, and now he's on regular follow. So the discussion part, this already, I discussed the thing. Just I'm going to the main the things. The paraneoplastic syndrome is the non-metastatic hepatic dysfunction. It is mostly associated with, there are many malignancies in our, but mostly with the renal cell carcinoma and the lymphoma. So it's first described by Stauffer. So it's name called now Stauffer syndrome. The proposed mechanism of this rare entity is the overexpression of cytokine interleukin 6 by the tumor cells. That is the reason. Okay. So there are the publications for the idiopathic cholestasis as a paraneoplastic manifestation in Hodgkin's lymphoma, and idiopathic intrahepatic cholestasis as an unusual presentation of the Hodgkin's lymphoma. Similarly, there are the few publications. The complete remission of paraneoplastic vanishing bile duct syndrome after successful treatment of Hodgkin's. So they treated the patient with Hodgkin's, the patient recovered from jaundice. So I'm concluding the first presentation here, and the paraneoplastic syndrome wise, they're explaining the two types of manifestation in Hodgkin's lymphoma. One is the simple cholestasis. That time the architecture will be fine, biopsy. Another one is the vanishing bile duct syndrome. So that time the biopsy will show the absence of bile duct. So vanishing bile duct syndrome, normally the literature says poor outcome. But the simple cholestasis, what we are seeing, even though bilirubin was 42, and simple, there is biopsy shows the simple cholestasis, canalicular cholestasis. So outcome will be. Now the patients on regular follow-up now recently. So I hope, but patients clinically much better, and the symptoms has slightly reduced. And I hope the patient slowly will come out very well. As we identified the cause, and we identified the reason for jaundice. Okay, thank you. Any questions?
Dr. Joy, this patient was almost on treatment for 3 months before reaching you. Did he receive any steroid during that period?
Yeah. So we gone through the reports of that previous, and he was not on the any steroid therapy.
So what is his response to steroid now?
Now actually, because the very short, and now we started the steroid almost within a week only. But even because already before to start itself, we subjected by mistake by the plasma exchange. So that itself he felt somehow, because jaundice, the number has come down, he slightly felt better. So I'm sure because of the existing disease, the bilirubin level will go high again. But as we have started a steroid, slowly he will recover very well.
So this we are assuming as a paraneoplastic syndrome. Do we get this histological picture in that?
The paraneoplastic syndrome of the manifestation, histology wise, very difficult because it can present as the non the same organ related some other manifestation. Suppose we know HCC will cause diarrhea, but diarrhea something we know there is a paraneoplastic syndrome, but we have to, before that we have to rule out normally all other etiology of the diarrhea. So, but biopsy wise or anything we can't. But this all the, by ruling out all other routine etiology and other thing, finally only we can label it as the paraneoplastic. And the main thing, one of the response of the therapy, because we are not going to treat the itching now, by treating the cause. Now the Hodgkin's lymphoma diagnosis, by giving that improvement in the jaundice will be the answer for the paraneoplastic.
Thank you.
One question, sir. When do we do plasmapheresis in cholestatic liver disease, sir?
Normally, we will do plasma exchange for the cholestatic jaundice whenever the patients come here with severe symptoms and bilirubin more than 30. Some patient even 25 we had done bilirubin, because suppose, for example, I can say we have a patient with this anabolic steroid induced cholestatic jaundice. So he came young boy, going to the gym trainer, and he used to take anabolic steroid for that. Severe cholestasis he came. So that time there was a significant improvement is there. Because the liver cell is not like a failing cell like a ACLF or ALF or a decompensated chronic liver. Here, there is a simple cholestasis. If you are going to do biopsy, the hepatocyte and the sinusoid, the liver architecture will be maintaining except mild inflammation. So that time, this symptomatic improvement, it is not the treatment, just a symptom improvement once the bilirubin level comes down. Any other questions? Hello? Shall we move on to the second one?
Yes, sir.
Okay, thank you. This also, I mean, the pseudo pancreatitis, this is might be, I mean, simplest one to all. Just I'll go through that. So this 51 years old gentleman from Pondicherry, you know, they usually consuming alcohol more and no comorbidity. He came presented with upper abdomen pain, acute, 4 days, and classical features of pancreatic pain, radiating to back and increasing with the food intake, all the things, and the vomiting episode, everything. He had a similar episode almost 1 year ago. Again, I mean, mostly the alcohol after the binge of alcohol intake. That time he was diagnosed as acute pancreatitis, and he recovered very well by the conservative line of management. And now he come with again the pain, with a severe pancreatic type of pain. So clinically we diagnosed, okay, acute pancreatitis, but when we examined the abdomen was distended very well, okay. So he had a mild low grade of fever and other things. These are the routine history, and weight loss, no history of steatorrhea. So no feature suggestive of chronic pancreatitis like the exocrine deficiency, or this patient doesn't have the endocrine deficiency also. General examination normal, but the per abdomen examination showed the epigastric fullness. We know because of severe pancreatitis, the gastric bloat and other things. Or confined, sometimes pseudocyst also will come like this. So clinically, it looks like a cystic inconsistency, mild tenderness. So now, and this is the lab values, and his hemoglobin was at 11, and the WBC count, as usual, the pancreatic 25,521, and the amylase lipase was, I mean, high, I mean 700, 200. LFT is observed normal except alkaline phosphatase 364. So initial ultrasonogram showed there is a large 14 centimeter and 12 and 9.3 and 12 centimeter collection in the epigastric region, almost averting the structuring all the surrounding structures, and there is no solid component in the cystic lesions. CT abdomen was taken, which showed there is a large well circumscribed pseudocyst, almost 11 centimeter in size and close proximity to the liver and the homogeneous, and mild ascites and bilateral pleural effusion. This is the CT abdomen. So here we can see this is the entire, what the first one A shows the pseudocyst, the big pseudocyst. And if you see that below that, there is air with the fluid, that was the stomach. So entirely the stomach was pushed. If you see this cut, if you see the second 1B, here we couldn't see the stomach here, but whatever the white, the dot sees, it's like a capsule, I think, that is the compressed the stomach. So such a large pseudocyst and thick-walled pseudocyst with abdomen pain. So we did an endoscopy, you know, so already stomach is totally compressed, collapsed. So it was the, I mean, the gastric lumen is totally collapsed. And then our side, Dr. Mahadevan, we asked to do that. And Dr. Mahadevan did the endo-EUS, and pseudocyst was, the cavity was punctured using the 21 French FNA needle. And the sterile cystic fluid was collected, and that was sent for analysis. And he put a double pigtail stents. And that time what happened, that one of the stent went into the pseudocyst because it's a big pseudocyst. Then he put one more stent there. That time he called and told that, I mean, he tried, but one of the stent slipped into the cavity. So once all the fluid gets drained out, we can easily remove the thing's not an issue, he said. Okay, fine, that's and this was the endoscopic cystogastrostomy was done, and the plastic stent was inserted. And the amylase was very high, and glucose and the gram stain. Here the things, I mean, the pseudocyst fluid culture report revealed Candida glabrata, and it was sensitive to the fluconazole. So the fungal identified, it was, I mean, when I discussed with my colleagues and other things, pseudocyst culture, the fungal comes, whether it is an incidental finding or whether it is a contamination and other thing. And the most of the thing, I mean, no, because under the aseptic precaution, everything is done. And mentioning the glaberata and other things, it's also very specific. Actually, our ID people told better to stop the fluconazole. They didn't think it is a contamination or anything. They said it's an infected fluid only. So subsequent ERCP was done because of such a big pseudocyst, whether pancreatogram was done using ERCP, whether any communication of the pancreatic duct with the pseudocyst, and so that it showed almost there's a PD in the head region was dilated, irregular. It's a pancreatogram showed along the branch duct. Distal pancreatic duct couldn't be cannulated and not visualized. So that time he some stones was swept out from the, I mean, even though it is initially not thought about the chronic pancreatitis, but not missed in the CT scan, but pancreatogram we identified and removed. That time he put a plastic stent and in the proximal PD. And what he said as the distal duct could not be cannulated, and there is some more chances. There is a distal pancreatic duct rupture. It might be has some communication with the cyst. So we have put a stent with